All right, good morning. I hope that folks can hear me. We're going to get started. I am Tracy Gonu, the Community Food Systems Developer for the Oregon Food Bank. And one of our goals for our statewide network team is to support food systems advocates across Oregon through the Feast Leadership Network. And one of the ways we do that is through these quarterly webinars on topics that you've suggested. We have covered topics on nutrition and garden education, storytelling, community organizing, and farmer networks. And today we're going to look at how healthcare partnerships can address food insecurity through various screening and program interventions. We're joined by the experts in the field, and it's my pleasure to introduce them to you today. But before we do that, a few housekeeping items. If you could keep yourself muted to minimize the background noise, that would be excellent. If you have any questions, please chat them in or type them into the chat box, and we'll have time at the end for Q&A. And if you do have trouble with sound, that's where I can troubleshoot with you on the back end. And just so you do know, this webinar will be recorded and made available on our website in about a week. I'll send out a link to everyone as well. So I'm going to advance the slide here and just show you what our agenda looks like today. We'll begin with some background on the social determinants of health and screening measures. From there, we'll look at 3 specific program interventions to address food insecurity: Veggie Rx, a subsidized CSA, and a mobile healthy food pantry. We'll end with some next steps and time for Q&A. And again, as I mentioned, please type your questions into the chat box at any time, and I will address those to our speakers at the end. So here's a look at our speakers today. I'm going to head and read their bios all at once and then pass over the mic to our first speaker. Lynn Knox is the State Healthcare Liaison for the Oregon Food Bank. In this role, she works with clinics, hospitals, and health systems across the state to provide training and technical assistance on implementation of food insecurity screening and intervention, and to facilitate healthcare involvement in addressing food insecurity and nutrition through other means. Options include produce distributions, cooking, gardening, and smart shopping classes, on-site food pantries, or produce prescription programs with other community partners. Increasingly, food is used as a flag issue to identify families in distress that need assessment and assistance with a broader set of social determinants of health. On the policy level, Lynn has worked with the Oregon Health Authority to develop a food insecurity screening and intervention Medicaid performance improvement metric, and to incorporate the 2-question screening into other patient assessment tools. Her work at the national level has included advocacy for the incorporation of food insecurity screening into electronic health record systems, and she has served as the facilitator for a learning exchange about healthcare engagement with food banks across the U.S. Lynn's past work has focused on health education, criminal justice reform, and poverty reduction. Before starting at Oregon Food Bank, Lynn led the City of Portland's development and implementation of the Economic Opportunity Initiative, a comprehensive poverty reduction program that won national recognition for the significant income increases achieved by over 3,000 participants. We're also joined by Sarah Sullivan today. She is the Executive Director of Gorge Grown Food Network, a nonprofit working to build an inclusive, resilient food system in the Columbia River Gorge of Oregon. As former Executive Director of both Hawaii Seed and the Organic Seed Growers and Trade Association, she has extensive experience in movement building, organizational management, and agriculture policy. She directed the award-winning school garden program at Abernethy Elementary in Portland, and trains teachers in garden-based education as an adjunct professor at Lewis and Clark College. Most recently, Sarah and her staff launched one of the most robust veggie prescription programs in the nation across 5 counties in 2 states with 40 healthcare providers. We're also joined by Brian Frank. He is an assistant professor and full-time clinician in the Department of Family Medicine at Oregon Health and Science University in Portland, Oregon. Since 2011, he has had the good fortune to provide healthcare to multi-generational families and individuals in all stages of life at the OHSU Family Medicine Clinic at Richmond, a federally qualified health center for low-income families. His research is focused on addressing food insecurity and other social determinants of health through collaboration between primary care, community wellness, and health information technology. Outside of his clinical duties, Brian is a Clinical Innovation Fellow with the Oregon Health Authority and serves on the executive board of CSA Partnerships for Health, a collaboration of local farms, universities, and public health entities studying the benefits of CSA prescriptions for patients in a primary care practice. In addition, Dr. Frank is a member of the Teaching Kitchen Collaborative, a national research collaborative evaluating the impact and scalability of teaching kitchens in medical centers across the country. Outside of work, Dr. Frank is an avid home chef. He has been experimenting in the kitchen since his first attempt at making a cake at the age of 5. Fortunately, he is a quick learner. He is rarely happier than when in the kitchen preparing food for his family and friends. And finally, we're joined by Philip Yates. He has worked for Access for over 24 years. He managed the Access Resource Development Department for 6 years, including agency-wide fundraising and marketing. He has also worked for 18 years as the program director for various nutrition projects, including oversight of Access Food Share, the regional food bank for Jackson County. He has served 2 terms as the chair of the statewide Oregon Food Bank Network, and in 2008 received the Oregon Food Bank Network's statewide Hunger Buster Award. In addition, Philip has a wide array of experience in administration and coordination of professional networks and volunteer groups, and has served on several local nonprofit boards. An amazing lineup today, and we'll go ahead and get started with Lynn. Welcome.
Good morning. The Oregon Food Bank decided to place a major emphasis on healthcare and nutrition in 2013 and 14. With the implementation of the Affordable Care Act, there was recognition by the Children's Hunger Coalition and also the Oregon Food Bank that a major initiative to develop partnerships and implement programs with healthcare was now really possible. And the reason is what you see before you. It's the social determinants of health. This is a concept pioneered by the World Health Organization some time ago, but really just taking hold in healthcare now. It is the understanding that the portion of your health that is controlled by what happens in the doctor's office is really only about 10%, and that the other factors you see, including what you eat, where you live, what you do, are the real determiners of your health. So with this knowledge, next slide please, we need to look at where we are related to all those factors, and we're not in a good place. Over half of Oregon's children currently qualify for free and reduced lunch. 71% of the Medicaid population is food insecure, according to a survey taken by the Oregon Health Authority. The CDC says that 86% of healthcare costs are due to diet-related chronic disease. So we've got to do something to address these diet-related diseases. And the good news is that when we implement food insecurity screening, our preliminary evaluations are showing that 72% of the people who are screened and then given some support in a healthcare setting around accessing food and nutrition education, 72% learn about something new. That's kind of sad in a way that it says that a lot of people didn't know what's available to them, but it's an important reminder that we've got to do this kind of outreach to connect people to just what's available now. And we all know that what's available now is not quite enough. Next slide. The entire transformation of the healthcare system in the United States is centered around what's called the triple aim. The equal goals of improving health, lowering costs, and providing better care. And this is what gives us such opportunity with the healthcare system, is that they are now focused on a set of metrics that actually requires them to lower the disease rates of people that they care for and to really show that they are improving health. Next slide. So one of the messages we try to share with people in a healthcare setting is that they can try nutrition first, and we want to partner with them to share ideas about how to do that and share resources about doing that. There is such a high correlation between food insecurity and a poor diet that there's just no doubt that all of these different kinds of conditions can be impacted by better nutrition, and that unless people can afford it, they're not going to get better nutrition. So we need to drive them to what is available to them right now and build new resources for better food. Next slide. So in looking at nutrition first, the first thing that a clinician needs is information about their population. That's why most clinics and hospitals start with a screening first, because they need the information to figure out what to do and who to do it with. When you do the screening in a healthcare setting, it is something that gives you the ability to target a population that needs special help, because in general, clinics are not able to help absolutely everybody. And if someone has indicated on a screening that they're having challenges getting adequate and healthy food, then it establishes a level of motivation that you can work with them from. So we work with clinics where they are and with what interests them most, but often it's establishing this screening so they know, okay, if we're going to do anything else, who should we do it with? And a critical issue that often is not really thought about is that the information about food security drives the diagnosis and treatment sometimes for patients that day of the visit. That if a clinician is seeing certain symptoms, he may think or she may think that it's depression or ADHD, when in fact it's really food insecurity that's driving certain behaviors and certain feelings and moods. It is not necessarily related to some mental health crisis or some physical crisis. And if the clinician does not address the food insecurity and have the information about the food insecurity problem, they might diagnose and prescribe psychotropic drugs that would cause various side effects and be ineffective or unnecessary. Next slide. So we provide tools and the validated questions for the clinics and hospitals to implement this screening. We urge it to be implemented in writing because people are more likely to reveal their food insecurity. We've tested it both ways and know that in writing is best. We have worked to implement it through the electronic health record systems because that's what makes it simple for clinics. Now, having worked with over 200 settings across the state, we've got techniques and workflows we can share from one clinic to the other about what makes this easier to implement and makes it work with all the different staffing assortments that clinics have across the state. We really want the clinic to figure out, and we work with them to figure out how to connect with that food insecure patient the day of the screening and review the resource list that we provide with them and connect them to some of those resources that are new to them the very day of the screening, because the sooner you can capture them and connect them to that resource, the more likely they are to actually use it and pursue it. So we identify a community health worker, a nurse, a trained volunteer, or maybe a intern from a master's in public health program or a nursing program that can consistently work with patients on these issues. And if they need it, we'll provide training to help them figure out how to address the things that come up. Next screen. So these are the two questions that are being used nationally in most places, derived from the U.S. Census. And the next slide is a sample of the one-page resource list that I work with folks from each county to develop, that includes everything from SNAP to the pantries to the special youth resources to SNAP Match to any education resources that we can find available in that county. And then the person that's reviewing this list goes deep, taking about 10 minutes or so to find that pantry that's closest to someone that they didn't know about, to actually enroll them in SNAP if they're not enrolled, to find a class they can take and help them get signed up, whatever seems to be the new item for them, because people usually can only handle one thing a day. This fits into the electronic health record system in the clinic, so it's easy for them to store, and things are updated behind the scenes and they don't have to worry about that. Next slide. Sometimes it's incorporated in a broader health assessment that the clinic's using. Sometimes food is used as a flag issue to then trigger a broader social assessment screening that looks at multiple social determinants of health and provide assistance, whatever the priority issue may be. Next slide. We found a lot of support for this work around the state. A lot of clinics and hospitals have implemented this, and that enabled us to work with the state to develop a standard approach through the Oregon Performance Improvement Metric, which will give us the ability to start collecting some data actually about the screening. As for food bank, we haven't had leverage to say, send us your results. But now, using the performance metric that the state has developed, if they choose to select this as their metric, they will report to the state and will be able to have a sense of what's going on. Next slide. Okay. So one of the things that we find is that after a clinic has begun screening, they really often come back and say, hey, we realize there's a much greater problem here than we thought, and we want to do something more. We want to be able to have something really tangible to share with patients. We do like the referrals. We think that's valuable, but what more can we do? So we pulled together a few examples of that for you today, and those are the next speakers.
Thank you so much, Lynn. And just another reminder, please make sure your mics are muted. I don't have control over that over on my end, and I can hear some background sounds coming through. So that would be greatly appreciated if you could mute your mics. Our next speaker with us today is Sarah Sullivan with the Gorge Grown Food Network. Welcome, Sarah.
Thank you, and thank you everyone for joining us today. As Tracy said, we are based in the Columbia River Gorge in the border of Oregon and Washington, and we serve 5 counties on both sides of the beautiful Columbia River. Next slide, Tracy. So this is our mission, to build a resilient and inclusive regional food system that improves the health and well-being of our community. Next slide. And the Veggie Rx program is just one of an interrelated suite of programs that we run to bolster our local food system through a really holistic approach. So I'm going to zip through this slide and some of the others, but my hope is that you can come back to them and learn a little bit more about our organization. So next slide. This shows the structure of our Coordinated Care Organization, or CCO, as Lynn was talking about. The 2 committees shown in the green boxes help our CCO leaders decide where Medicaid funding goes. So I just want you to take note of this Community Advisory Council, or CAC, on the left, which is made up of 50% Medicaid recipients. I'm going to mention that later. Next slide. So the CCO is required every 2 years to do a community health improvement process, and I can't stress enough how much this assessment was really important for us in making our program a success. So basically 40 stakeholders came together to survey thousands of community members about their greatest needs, and under the social determinants of health, food insecurity was prioritized as a very top need in this area. Next slide. The Columbia Gorge Health Council dove a little bit deeper into that issue and basically found that 1 in 3 people here worry about running out of food, 1 in 5 do run out of food, and 1 in 7 skip meals. So it's really, really epidemic, and this just really helped raise this issue to the forefront of organizations throughout our region. Next slide. And what we learned is that food assistance programs that are existing are not enough. So you can see that folks that are on SNAP and WIC actually still have a higher rate of hunger and food insecurity. Next slide. So August 2015, we launched our Veggie prescription program. And this is how it works. It's totally based on food insecurity as the qualifying factor that gets people Veggie Rx. That's really, really different than a lot of programs around the country. So we're not centered just around addressing diet-related disease, and that's really important. We believe that hunger is a health issue. So when folks go into their clinic or the health department or a number of other distribution sites, they are asked those 2 questions. Or last 12 months, did you and the people you live, or did you run out of food? If they answer sometimes or yes, they are given the vouchers. The vouchers are individually numbered for tracking. Those people can use the vouchers at farmers markets in the summer or grocery stores in the winter. And then the markets, groceries, or farmers send the vouchers back to Gorge Grown Food Network, where we track them and send a reimbursement check. One really important thing was we focused on making this as easy as possible for healthcare providers. So all that they do is collect the recipient's first and last name, number and household, phone, and email. And that was really important to make their workflow easier. Next slide. So before we knew it, for better or for worse, we had 40 clinics on board or distribution sites and 30 groceries participating in this program. And one real success was not just distributing through hospitals, but where people go when they are in really dire straits. And that includes senior centers, health departments. We distributed through Head Start, through low-income housing centers. And Some of you in urban areas might be asking, how did you do that? We're lucky living in a rural area. We have a lot of personal contacts and friends who work in these facilities or work at grocery stores. We had a very concise one-page program description to explain what we were trying to do, and just again making the redemption and workflow really easy. Next slide. So I won't go through the stores, but I just want some of you who aren't from around here to know that some of these places like Dufur are 50 miles from another big grocery, and some of the towns that started redeeming vouchers had never before carried produce. So this really helped provide access to some super rural areas. Next slide. So over the 8-month trial, we served about 6,500 people. And out of the almost 7,000 that we screened, about 33% were food insecure. And the average redemption rate, meaning those people who actually used the vouchers that they were given, was anywhere from 75 to 98%. So next slide. You can come back to this crazy one, but basically I wanted you to see that some of our highest redemption rates were among senior centers, which is really unique because you probably know that seniors have a otherwise low participation in other nutrition incentive programs. And you can also see that at some of our more rural health departments, we had 99 or 100% of the people there screening positive for food insecurity. So again, just going to meet people where they are. Next slide. Farmers obviously love this. Over $75,000 went back to our local farmers and groceries during the pilot. And one important thing was working with farm stands. So we had a lot of those here in the beautiful Columbia River Gorge, and they're open 7 days a week as opposed to farmers markets, which, as you know, have limited hours. Next slide. Another successful part was working with Oregon State University to facilitate community meals where people were recruited specifically from the Veggie Rx program to participate in hands-on cooking classes. The one called Cooking Matters was the one that worked best for us. One thing we did learn is that it was hard for people to get to the classes sometimes, and they didn't always stick with the longer series of classes, so we're just kind of learning, retweaking, providing one-off or shorter series in the future. Next slide. Another thing that worked great was partnering with a whole network of other social service agencies. So this is Vitalina Rodriguez on the left. She's a community health worker with One Community Health. She's also a farmer, and she's here on the floor in a migrant labor camp visiting a new mom and her baby, and this really helped us reach people that we otherwise wouldn't have been in contact with. Next slide. We did an evaluation called Photo Voice. This was really interesting. It basically puts cameras into the program participants' hands to be able to critique and improve the program from the inside out. So this provided a space for participants not only to evaluate the program with and for us, but to meet in focus groups to share their experience about living in poverty and to find friendship and support in other ways. So you can view that whole report on our website. And these are some of the things that they said. So next slide. You know, just incredible stories about lowering stress, which was really important. People getting better more quickly from illness. Next slide. People talking about the fact that you can't find coupons for fresh produce, setting an example for their kids. Next slide. And the stories that we heard proved that people were eating better, they had better management of their diabetes, they were they had less stress, they were more financially secure, and they were really proud to be contributing to the local economy. Next slide. You can't really see this, but for you logic model lovers, we made this, and if you want to come back to it, it's what came out of that evaluation. Next slide. So this is where the funding came from. Over $50,000 from individual donors. One Community Health, our federally qualified health clinic, donated about $26,000 for Veggie Rx vouchers in particular. Providence Memorial Hospital, through their community benefit dollars, allocated funding for evaluation and vouchers. Oregon Community Foundation helped us with staffing. And then the Columbia Gorge Health Council, a coordinated care organization, donated $15,000 out of their general operating funds. And all of the other hospitals in the area contributed, South Skyline and Mid-Columbia Medical Center. We also had funding through local businesses like Tofurkey. Next slide. And the challenges, of course, are long-term funding. We are struggling to find out how to really sustain this, as I'm sure you all are. Tracking vouchers got tricky. We really need a card or a scanner system. We found out that a lot of folks that weren't able to use their vouchers had trouble with transportation. Some of them were ashamed to use them. Funders want in-depth quantitative data, and we are not able to do that as a nonprofit with lots of other things going on. And funders want to end hunger in a short period of time, and hunger is actually chronic. Our visionary director of our coordinated care organization, Kristen Dillon, said this: it would be easier to focus on diet-related disease, right? We can improve outcomes more easily and quickly by treating people who are already very ill, but we want to continue to elevate the conversation around the fact that we can prevent illness and empower people to find wellness and security before they're sick with healthy food. So that's the pickle. Next slide. Who's on board now? I think that One Community Health, our federally qualified health clinic, and Columbia Gorge Family Medicine are the first two clinics in the country to allocate funding through their general operating budgets to fund veggie prescription. Our next trial is going to be at Hood River Health Department with pregnant moms on WIC. And WIC already tracks dozens of metrics, so we can easily do some quantitative analysis without extra funding and staff. And if any of you around the country are interested in doing a trial in tandem, it would be really great to compare the impacts and outcomes of that. Next slide. Just to wrap it up, we're also working on a regional food security coalition to work on a really long-term strategy for how to continue to bolster our local food system. Next slide. And we've also really been working on empowering our Veggie Rx recipients to show up at those CCO meetings, to advocate for themselves. And in part because of that, this isn't written in stone, but it looks like our CCO, Pacific Source, is planning on pulling about 15% from their quality incentive metrics and 75% of their gain shares for social determinants of health over the next couple of years. That'll be spread kind of thin between affordable housing and other things, but it's a really, really exciting time here. Next slide. We're really honored to win the Culture of Health Prize from Robert Wood Johnson Foundation this just last month, and a bunch of us are going to be participating, and I really hope this elevates our work nationwide around healthy food advocacy. Next slide. And this is our vision, that we have a self-sufficient food system where food is produced with integrity and valued, abundant, and accessible to all. Slide, and there's my contact info. If you want to call or email me, I'd love to help anybody make a program like this happen elsewhere. Thank you so much.
Thank you so much, Sarah. Really appreciate your presentation. Next up, we have Dr. Brian Frank. Are you with us? We'll give him a minute to unmute.
Yes, sorry, I was trying to find the mute button.
Great, welcome. Thanks for joining us today.
Thank you. Sure. Thanks for having me. All right, so just a bit of housekeeping. This is what I look like for those of you that don't have a web video. And for those of you who are in Michigan, my fellow Michiganders, there's a call out at the lapel. Next slide, please. why is a doctor on this call? Why should I be involved in this? Why do I even care about food insecurity? Next slide, please. This is the classic picture of food insecurity. Next. Food insecurity can also look like this. Next. It can look like this, but for me, it most often looks like this. This can lead to us feeling incredibly frustrated, not only because we can't help our patients treat their illnesses, but because we just feel a sense of powerlessness in general, trying to get our patients what they clearly really need. Next, please. One possible solution came up, as most good things do, over a cup of coffee and a conversation between Zenger Farm and one of the Multnomah County clinics. They talked about the possibility of getting CSAs available for low-income families. So Zenger Farm got a USDA grant, and Multnomah County reached out to OHSU. There was a night cancer grant given. We then reached out to Portland State University to do the evaluation portion, and thus was born CSA Partnerships for Health. Next. Initially, CSA Partnerships for Health was a CSA delivery to a number of different businesses. The first was a gym, second was a naturopathic college, there was a church, and of course the Multnomah County Health Center. We're going to focus on the health center for today because I really think it's the most successful model, and we'll talk about why that is later on when we look at the data. Next. Next. How does this start out? Well, anyone in the office, be it a nurse or a behavioral health, community health worker, or the PCP, can put in a referral for the CSA project. And you can see behind the lettering what the basic referral form looks like. This referral form is sent to the project, and then there's a lot of magic that happens behind the scenes. Next. Part of that magic is the community health worker who in last year's project was instrumental in getting patients involved, getting patients to the CSAs, getting people signed up. Next. Once the project started, 25 families were able to get CSA shares once a week. It was subsidized at 75%, so a $20 box would cost the patients only $5, and we can talk about how that was subsidized later. This program ran for about 24 weeks in 2015 with a weekly pickup, rain or shine. Next. This is one of the actual boxes, and you can see on the right side of the screen there's a card in there. I will talk a little bit more about that, but these were educational components as well, how to use the vegetables that they're getting. And as you can see, next, there's a big variety. One of the benefits of the CSA model is people are really forced to try vegetables that they might not otherwise try. Next. This is a mid-season box. Next. And this is what it looked like in the fall. As you can see, a rainbow of colors, a variety of different types of vegetables. We also were fortunate that we had a local business donate some of their fresh grains to the boxes as well. But that's not a requirement for this project. Next. We also had cooking demos, and as I said, we gave out skill cards in English and in Spanish. We gave out cards on not only how to prepare the vegetables, but how to save them, because obviously if you're getting a box full of vegetables and you can't use it, you don't want to see all that go to waste. You'd love to be able to save it for the off season as well. Next. We also did a farm visit which was really incredibly well received, and it helped foster this sense of community and of really belonging to something bigger and more exciting than yourself. It let people get to know the farmers and put a personal face on the produce that was being given. Next. All right, the data slides. At the beginning of this project, we were not surprised to see that the folks at the Mid-County Clinic, at the Multnomah County Clinic, felt like their health was worse than many of the other participants. Nearly half felt their health was either fair or even poor. Next. There was also a report of about 40% food insecurity at the outset of this project. These are people at the Multnomah County Clinic as compared to folks in other components of the population. Next. One thing that we thought was really heartening, though, was that 3/4 of the people involved in this project wanted to join this CSA program to help improve their health. It wasn't just, we need more food. It wasn't just, look, there's free things, we need assistance. But these people really want to improve their health, and they see fresh produce as a way to do that. Next. Next. So then we get to the post data, which was pretty exciting for us. 80% of the members of the CSA felt that their health was better, not just after the program, but because of participating in the program. Next. 100% of the people at the Multnomah County site reported eating a greater variety of vegetables. So it showed that if you just get the produce to the people, they'll eat it, they'll use it. Next. This is a slide that I think is fascinating. We didn't talk about soda. It wasn't a part of the intervention. It wasn't a part of any of the formal education, and yet, if you look at the pre and post, the total number of people that reported drinking no sugar-sweetened beverages nearly doubles as after the intervention, after the CSA. Next. Next. So how can you do this? How can you take this on at your clinic? It sounds like a pretty big project, and it can be, but we have ways of helping make it easier. Next. We have a toolkit that will help, and I should say we have a free toolkit. I'm not selling anything except, I don't know, fruits and vegetables. There is a sheet that you go over with your farmer and talk about what the roles and responsibilities are. Next. There are explicit tasks that need to be coordinated that you go over with the farmer ahead of time. Next. There's obviously an MOU that needs to be signed, and there's one available. Next. And this is basically what the timeline looks like. In November of the year prior to when you want to implement the CSA, you start looking for a farm. Now, for people in Oregon, especially people in the Portland area, we can certainly help try and identify some farms. There might be other resources in other parts of the state or parts of the country that can do the same. Once you've found a farm partner, then you just follow the timeline here. So there are a lot of meetings early on. In December, you do the needs assessment. In January, you start defining the roles and you sign the MOU. You begin the marketing strategy in February and start to figure out how you're going to get clients involved, who the clients are going to be, whether or not they need to have a pre-existing condition, what your targets are going to be as far as interventions if you decide to study this. And then the season runs from June through November. It may be different for different growing regions. There may be CSAs that are able to provide produce all year. And then once it's done, you look at the evaluation component. Next. A couple of things that are instrumental in making this work. You need to have a dedicated person at the farm who will be there for pickup every week, so that people that come to pick up the produce have a familiar face. They can get to know the farmer, they can get comfortable with them, so that they can start asking questions that they might be afraid to ask a stranger. It also, again, it helps personalize the relationship with the farm. Next. The other person that's imperative to have is a community health worker or other dedicated staff member whose job it is to really be the cheerleader for the program, both who can spearhead it with the staff and let them know what's going on, but more importantly, who can be that face of the clinic for the patients. So if questions come up, if people need a little bit of prodding, if reminder calls need to be made, this person is the one that patients will know to go to. Next. And next. So this year, in addition to Multnomah County, at the Mid-County Clinic, we've added 3 more Multnomah County clinics. We've added an OHSU federally qualified health center, and we've added a housing project to our ranks. We've got 6 farms total, and the season is nearly done. It'll be done later this month, and so far it's gone great. Next. The cost of the boxes, as I said, is about $20 a week. We have been working on a 75% subsidy. This roughly comes out to a cost, I want to say, of about $600 per patient. Mike Wenrick from Zengerfar was on the phone, and he can correct me at the end. We've been using a 75% subsidy that we've essentially gotten through grants at this point, although we're looking at ways to make this a little bit more permanent. We were fortunate in that these have been SNAP eligible purchases. We have a way to let people use their food stamps to pay for these boxes directly. We automatically withdraw. It's a little bit more of a complicated process that I'm happy to talk about offline. But just know that if you can involve SNAP, it's a real benefit. No pun intended. Next slide, please. Okay, so how do we make this work? Next. There's this payment method called health-related services, flexible services, and community benefit. Not to go too deep in the weeds, but the Oregon Health Authority and the CCOs, the way they run Medicaid is to have some funds available for not directly medical related costs. So for example, it's not paying for an office visit, it's not paying for a medication, but it's paying for things that patients need that will help improve their health. That's one possible mechanism for paying for the CSA boxes. Next. In addition, in this year's Medicaid waiver, the Oregon Health Authority has specifically vowed to address social determinants of health and equality using flexible services and community benefit initiatives. There is also a lot of interest at the state level in learning how to properly screen and potentially even intervene under the auspices of Medicaid. So my dream is that one day I will be able to write a prescription for a CSA that will be covered by Medicaid the same way metformin is. Next. So in summary, this is not impossible, and we can help you make this work. You have to identify a local farm partner. You have to find a funding source until I have my dream come true. You have to find your target population and a clinic champion. And then the CSA starts. Thank you very much.
Thank you so much, Dr. Brian. Really appreciate that presentation. We will have time for questions at the end, the very end, and there are a lot coming through. So Brian, get ready for those. Next up is Philip Yates with Access. Are you there, Philip?
Yes, I'm here.
Excellent. All right, welcome. Thank you for joining us.
Thanks, everybody. Thanks for tuning in. I wanted to kind of describe a real practical program that we're implementing as a pilot program. We began the program really in January, setting it up, but really kicked off in April. So I wanted to kind of give you where we're at and how we got to where we're at this present point. Importantly, we are the food bank. Access is the food bank serving Jefferson County, and we had, if you've heard of the term, or it's pretty familiar with a lot of people, I'm sure, when all the stars align. But really, I think it's really, when that happens, I think a lot of the groundwork is already done. And I think the groundwork for this program really began maybe about 5 years ago. We were able to, next slide, purchase a mobile pantry truck. We had struggled in order to be able to service the whole county and providing emergency food across the county, to open up pantries in different communities, especially the rural communities of Jefferson County. So we were able to, with some discretionary money through the recession, after the recession happened, and trying to reestablish support for programs, we were able to get money to purchase a truck. You can see in this diagram, if you can imagine, if you've seen a Pepsi Cola truck, it has sliding doors. It is about 32 feet long. And so there is 5 compartments on either side of the truck. And we have installed a generator on board. We can also plug into a electrical outlet as well, so that we don't have the sound of the generator. But we have 2 refrigerators and a freezer on board, and we're able to carry about 5,000 to 6,000 pounds of food. As you see, we also have an awning here. We carry some carts for people to be able to do shopping. And we actually have people shop the outside perimeter of this food pantry. So this was really the basis of what became our ability to be able to do the mobile healthy pantry truck. Next slide. Along with that, we completed a very thorough community food assessment back in 2013. We had maybe about over 1,000 people participate in that process. It was mainly the feast process, but we interviewed individuals as well. As a part of that, people who we saw through the low-income programs that we run were asking for skills to develop their skills in the kitchen, but they didn't have the means to be able to go to classes necessarily, or to be able to have the resources to be able to drive there. So they were asking for information in the places that they already were. So we decided to adapt the train-the-trainer model of doing cooking demonstrations. And in the first year or 18 months, we had trained 90 volunteers. This was the biggest supported volunteer program that we've ever done here. And it's just amazing how many people came out of the woodwork that wanted to be able to transfer their skills to people in the community. So we now are able, because of that army of people, we're able to reach about 100 to 120 sites annually. We're at food pantries initially, and then we're also at growers markets trying to promote local food consumption, as well as local businesses, community events, groups, and other things as well. So this was able to add to the program of the Healthy Mobile Pantry. Next slide. So the other thing that played into this was the fact that we were observing within the food banking community a higher rate of chronic disease. We do a food survey every 2 years, and the last food survey that we did in 2014, these were some of the results that were there. 27% of the households that we serve had at least one member with diabetes. Compare that with 12% of Oregonians is diagnosed with diabetes. Also, 48% of households had at least one member in their household with high blood pressure. So the need for help with chronic diseases, nutrition was there. And I've always thought about the idea of having some kind of pharmacy, food pantry, particularly in the Medford area, that we could serve the Medford area. So this served as a springboard to be able to create the mobile healthy pantry. Next slide. So having some of these things in place, we needed to get funding for this program. One of the local CCOs were looking at funding at the beginning of the year, and we were able to get this program funded for 12 months. It aligns completely with their CHIP priorities, and I think we are building a relationship with them that will be long-lasting. We wanted to also have the expertise of OSU Extension, and we had the dietitian come and work with us to recommend certain items that we might have available for families on the truck itself, and to how to position and market products as well. We were looking for sites specifically where people would be able to be referred from. There are 2 community health centers in Jackson County. One is La Clinica Health, and the other is Rogue Community Health. La Clinica recently opened a wellness center, which was exactly the right place that we were able to open up there. So we brought the truck there, along with the cooking skills demonstration, and also a dietitian from OSU Extension to be able to provide assistance to families. Because many of the families that we're serving, we find that although they've gone to the doctor and they've been told that they need to change their nutrition, they don't necessarily know how to start that process and the support that they might need to be able to do that. We found that by having a dietitian there at the site each time we open, that the people spend at least 10 or 15 minutes in conversation around about what kind of foods would really be good for them. So it's been a really good springboard for us to be able to have that conversation and be able to help support the families that need this kind of help. Rural Community Health adds a component to that. They also do blood pressure testing at the site. And in fact, through that process, they caught somebody who was in immediate need of medical help, and they were able to get them in that same day to be able to provide them with medical help. Access provides the program coordination. Again, the stars aligned. We found a person who is the coordinator, who has a degree or master's in international public health, and whose specialization was in nutrition affecting chronic disease. So he is exactly the right person to be able to move this program forward and coordinate all the aspects of the program. Next slide. So just the referral process, we've tried to expand the referral process to hospitals. We have 2 major hospitals in the area, Prevalence and Asante Health. And also we're working with the wellness program at the YMCA. The CCOs are also another source of support and referrals as well. Next slide. So at the moment, we're still only about 5 months into the program. We have about an average of about 100 to 120 people using the food pantry each month, and they're receiving 5 to 7 days supply of food. We're purchasing some of the food, particularly some of the food we're getting locally. We run 5 or 6 organic food share gardens, and some of the food comes from that. But our commitment has been to increase the number of fruits and vegetables, and we're purchasing the rest. That refers to the cost of the running of the program, so we're trying to find out exactly what that cost might be as we move through this cycle. We're doing simple surveys of how people have, what kind of consumption and whether they're using fruits and vegetables at the time that they're coming initially to the food pantry, and then we're measuring that later as well. And we're also hoping to be able to measure the health improvement with health center clients with the relationship we built both with the community health centers. So I know I've gone past the time, so I'm going to stop there and give time for answering questions. Thank you.
Thank you so much, Philip. Really appreciate that presentation. We've got a couple more slides that Lynn is going to go over, who started us off today, and then we will open it to Q&A.
So as you've seen from the previous presentations, there's just a wide range of options that you can partner with healthcare folks on and move forward in your community. It all depends on their interests, resources, and your capabilities. One of the unique ones is that we often find that the healthcare staff do not know social service staff in their own communities. I've had people, I come from Portland to Brookings, Oregon, and they say, hey, will you bring us together with our social service people and facilitate a conversation? Because if we're supposed to address social determinants of health, it would be good to know each other and what we do. That seems so basic, but it's critical to creating a good foundation for development of partnerships. Next slide. And then once you figure out what you want to do, Brian talked a little bit about this, but there are major numbers of funding opportunities within the healthcare system that are fairly new and need to be pursued very strongly. Local hospitals have decreased the amount that they have to put out to cover uncompensated care by 66% on the average across Oregon. That means it's 66% more money that, because they're all nonprofit, they need to be putting out into the community. So look at their CHIP plans, help them develop those community health assessment plans, and then there will be a hook for improving people's diets in that community health assessment. And that's what they make their funding decisions based on. A big problem is that very few of the hospitals are transparent about their processes. So you will need to be aggressive about how do you make decisions, how do I apply. And then there are funds that the broader, more regional CCOs, the coordinated care organizations have, that they receive when they do well on decreasing disease and meeting other metrics. We're talking millions of dollars here, folks. And so it's really important to work with these partners that have new dollars available, not the old social service funding streams that are trickling down. We are talking a lot more money than was available a few years ago from a wide range of sources, and most of them need to be addressed from the local level. It's not something that a state organization like the Oregon Food Bank can apply on your behalf or for a statewide grant, because the local hospital is going to give to local projects and the regional CCO is going to give to projects within that region. Now, there also are larger health insurers in Oregon that may have a very strong interest in improving the health of their members and decreasing their costs that you can look to. And additionally, there are the side players such as medical equipment companies, electronic health record providers that are making a lot more money because so many more people have their health care funded. So don't overlook those either. Then the long-term sustainable solution in many ways that Brian talked about is this Medicaid billing option through flexible funds. And there are some coordinated care organizations throughout the state of Oregon who are already using that to provide food for their patients or transportation to a grocery store or other kinds of services that they need to stay healthy. But in 2017, once the new waiver takes effect, it will be much easier for these organizations to use those flex funds, and it will be prioritized, as Brian said, for them to do so. So please stay tuned to that. We will try to share information as it becomes available about how to encourage this practice. Next slide. So here's our contact information. We all are available to deal with specific questions, but we'll now go to the broader questions from the audience and see what we can work out together.
Great. Thank you so much, Lynn. And thank you to all of our speakers. In addition to questions that have been coming through, there's been a lot of gratitude shared and expressed. So again, thank you so much to our speakers today, Lynn Knox, Sarah Sullivan, Brian Frank, and Philip Yates, for taking the time to share what they know and their experiences with healthcare partnerships. We've had a number of questions come in. We have about 10 minutes left to go over them. I'm going to start with the ones that have already come through, and if you have any more, feel free to type them into the chat box. Sarah, this question is for you, so for all of our presenters, please go ahead and unmute your microphones. Sarah, how many participants also receive SNAP who participate in the Veggie Rx program?
We didn't actually formally track that, but I will say that in working on this collaboratively with our healthcare partners, one of the things that the CCO has prioritized is what they're calling pathways or bridges to health. And this is kind of like a cloud record-keeping system that those of you that are in healthcare probably could explain it a lot better. But basically, when somebody goes in to, say, the health department, their information will be on a shared platform where their community health worker, doctor, whomever can see if they have SNAP. If they don't, and they do qualify for food insecurity, then the provider can more easily direct them to not only those kind of services, but affordable housing. You know, we're finding that food insecurity is inextricably linked to unaffordable housing here because people pay for rent first, utilities second, food third. So this is helping all of us kind of look at health in a broader way. So that's a roundabout answer. But
Great. Thank you, Sarah. This is a question I think that could be addressed to all of our speakers today. One question that came in addition to the excellent programs to provide fresh produce, are there any programs to provide other food needs like dairy, protein, and healthy carbohydrates? Does anyone want to take a stab at that response?
It's still up here a little bit. We, because of the partnership we have in the community through a program called Fresh Alliance, we partner with most of the largest stores, including Trader Joe's and other stores as well. So we're not only able to provide fruits and vegetables, but also other products like dairy products, lactose-free milk, as well as gluten-free breads as well. So we're trying to diversify as much as we can, as much as the resources allow us to.
And we're working with a couple of clinics and a hospital here in the metro area to try and establish actually healthcare facility-based pantries that would have staples and fresh produce as well.
Great. Thank you so much. Brian, I think this question is going to go to you here. There's a few questions, logistical. One, I hope an easy answer for you is, can the CSA toolkit be shared?
Yes. Short answer, yes. Longer answer, I think my email is on this last slide. Please email me. There are some, it's free. We're not going to ask you for anything, but we need to, there's a process that we need to go through.
Great. Thank you, Brian.
To get it out to people.
Another question for you is, how long did the planning and pre-programming work take to get the CSA partnership up and running?
We started talking about this in, well, the conversations were going on for most of 2014 in more nebulous terms. We really started the planning of this, I believe, in October of 2014 and got it rolling by June of 2015. So I would say it requires a minimum of 6 months. Would be much better if it was more like 9 months.
Great. Thank you. I have one more for you. Can you elaborate on the process for funding the subsidy as well as involving SNAP?
Sure. So the funding is pretty simple. We just applied for grants, and we made it clear that some of the grants would be going to pay for the actual produce. And then we felt that it was necessary to have some buy-in from the patients in order to increase their perceived value of it. So we didn't subsidize it at 100%, but it was all grant funded. As far as SNAP goes, it's a process that I don't fully understand. I know Mike Wenrick from Zenger is on the call. If he wants to unmute and give us a better sense. But basically, it involves going through the Farmers Market Association of Portland. Mike, are you able to offer anything else?
Yeah, hi everybody. Yeah, the Portland Area CSA Coalition is doing SNAP reimbursements. So they all have the ability to accept SNAP benefits, and then the farms are reimbursed by Portland Area PACSAC, as they're known. So we give those grant subsidies to PACSAC, and PACSAC does the reimbursements.
Great. Thank you, Brian and Mike, for jumping in. One general question that we have is, the media bombards us with less than healthy choices. Is it possible to begin some public service ads depicting people from various lifestyles making healthy choices? An example might be the Kaiser ads for activities. Not sure if any of you feel like you can take this one, but I wanted to put it out there in case any of you hadn't had thoughts.
I would say yes, it is possible.
Great. You got a chuckle out of Lynn as well. Okay. I think that I don't see any other questions coming in. I would ask, I included a link in the chat box to a SurveyMonkey. There's 3 questions with an opportunity to leave some comments as well. Please take a minute to do that. It really should take just a minute. And within that, asks questions about future webinars. And then just, again, a general appreciation for all of our presenters today. Thank you so much for taking the time to not only prepare these slides in your presentations, but for being with us today and answering questions. We really appreciate all that you're doing to bridge the gap. Thank you so much for your time, and have a great day, everyone.
Thank you, Tracy. And a huge thanks to Tracy for putting this all together.
Oh, thank you.
Thank you.